The topic here is radioisotopic targeting of neuroendocrine tumors. I am a nuclear medicine physician. Again, I work at Georgetown here in DC. Our site was recently approved as an SNMMI, so Society of Nuclear Medicine and Molecular Imaging Comprehensive Radiopharmaceutical Therapy Center of Excellence. So these are a few centers and growing in numbers where we have to meet some qualifications for excellence in treatments of patients in general. And so radioisotopic, radiopharmaceutical, that's all the same thing. So I wanted to, what I'm going to do, I'm going to give you an overview of imaging, how we use imaging for the evaluation of neuroendocrine tumors, and then go to the part that deals with the actual treatment. So our tools of imaging in the evaluation of neuroendocrine tumors are, we kind of refer to CT, MRI a little bit to like structural imaging, anatomic imaging. This is not completely true because there's always a functional or biological characterization of tumors. But you can see, again, on the left side, CT and MRI that, again, have evaluate the structure. And then they also, again, how they characterize the anatomy, stage the disease, and also for the follow-up. Functional imaging, we refer to these days mostly for PET imaging for neuroendocrine tumors. Dotatate PET CT, we used to have octiotype SPECT CT, which is now vastly been replenished or substituted with the PET CT, and then FDG PET CT imaging. So the Dotatate PET CT evaluates the presence of somatostatin receptors on the tumors, and that gives us an information on the biology of the tumors a little bit, helps us with the stage, because usually when we add the PET CT to the CT or to the MRIs, we're adding information and we're adding better ways to characterize often the disease. So for staging, so initial evaluation of the disease, whether or not there are metastases, how much of the tumor is there. And then also PET CT helps us guide treatments and evaluate whether or not the tumor can be treated with our treatment, so the radioisotopic target treatment, and also restage the disease. And then we also have FDG PET CT, which we don't use that much in neuroendocrine tumors, but can be helpful. Sometimes we use it. Again, FDG PET CT looks at the glucose metabolic activity, gives us a characterization of the biology of the tumor, sometimes can help us with the staging, and gives us some prognostic information, meaning how aggressive is this tumor or not. So let's see. So in general, just to summarize, the goals for imaging neuroendocrine tumors is to do an initial evaluation, initial staging. So there is tumor, yes, no. How much of a tumor there is? If we're thinking about surgery, is just a tumor or there are metastases? So can the tumor be resected surgically or not? Again, evaluated overall how big is the tumor, how much of the metastasis there is, characterize the biology of the tumor. So how aggressive the tumor is, what are the characteristics of the tumor. Okay. So this is one example of a CT MRI. You see those arrows there. And these ones here, these more white are all lesions that are in the liver. And the CT or MRI are very good at that, and the MRI here also shows more, again, more of the liver lesions, but also gives us the information, the anatomical information that the surgeon will love, because they know at this point with imaging whether or not the tumor is close to some vessels or not, if there are lymph nodes, if there are other structures, if this tumor is essentially can be resected or not. So that's the kind of information a CT MRI can give us. This is another example, carcinoid of the small bowel. You can see these little dots here, more white dots, where the arrows are there's more than one. So the CT or MRI with the appropriate technique, and usually are very good at detecting whether there's only one tumor in the small bowel, there are multiple tumors, and also is looking at a lymph node here. So overall, really, really good evaluation by CT MRI. But here is why we do PET CT. This was a study that was done at the NIH in looking at Dotatate PET CT when compared to CT or MRI. This is the total number of lesions regardless of the type of tumor they were seen. You can see how 95% of the lesions were seen by Dotatate PET CT. Half of those were seen by CT or MRI, and that depends now, is breaking it up of whether it's pancreas, liver lesions, bowel or not. But overall, except with lungs, you can see that PET, when you add the PET information, you're more accurate in finding lesions. Except the lung, where the CT is actually quite good to look up for lung lesions. And this is one example of a PET CT. So where there's color is the PET part, and then there's a CT part, and you can see that there's one dot here, there's another dot here. So and I think there's one more here. So these are multiple lesions in the bowel, plus there's a lesion in the in a lymph node. And so even if the lesions are quite small, the PET helps us really being able to find the lesions. It's very easy to find these colored spots here. So PET is helpful in that. And this is one case that we had. This was a patient that had a lesion that was found by, had some neurological problems, and so had an MRI, and they found this lesion here. They did a biopsy. Final diagnosis was that of a clear cell neuroendocrine carcinoma, most likely low to intermediate grade, primary meningeal versus metastatic. So we have now a metastatic lesion of neuroendocrine tumor. It's actually quite important to find the primary lesion. And this is one case, one example of how PET can be helpful, because again, we did a PET, and you can see this bright area, which is the lesion that we just seen in the brain and the meninges. And then the PET shows a little dot here in the pancreas. And so then we did an endoscopic ultrasound biopsy, and that was found to be a primary neuroendocrine tumor. So finding the tumor is very, very important, and that was a very small tumor. So PET helped us find the original tumor. PET is also important in characterizing the tumor, looking how, again, the overall tumor burden. This is important, characterizing tumor burden. These are plots, you know, from derived from the NET1 study. I can now really barely see things here, but I'm starting to realize I need to put glasses. You know, so there are the patients here how much of a liver is involved, and again, it's the patients that do better, the patients that have less tumor burden into the liver, and obviously doing the Dotatate helps in the prognosis, overall survival of the patient, or progression-free survival. But characterizing the tumor also in regard to the liver, the amount of disease that's in the liver can be important. And these other two ones essentially say the same thing. Depending on how much, the larger the liver lesions are, the worse the prognosis, and smaller liver lesions can be more easily treated. At least with Dotatate, as it was done in this study. So lutetium Dotatate treatment. This is another case where the PET, what does a PET show? It shows, this is the whole body view, and you can see many dots here in the liver, and how is PET helping us? It's showing us, yes, there are multiple lesions in the liver, but it's also showing us that there are no other lesions outside the liver. That can be important for the approach. What do we do with the patients, right? Knowing that there's no disease outside the liver can be important. And again, remember, PET adds information, so things we are more confident in what we see become more accurate than if we're looking only at CT on MRI on average. And these are, again, small lesions, so it's also important to know that the lesions are small. As I said earlier, that can impact patient prognosis. This was a patient that had a diagnosis of a neuroendocrine tumor 10 years before, decided to follow up at a certain point, did a Dotatate PET CT, and you can see there are a number of lesions in the liver. But what is important in this patient also, that there is this lesion in the femur, and that can be very, very important to plan the treatment for the patient, with liver-directed or even liver surgery versus some more systemic treatment. Again, the use of PET in these cases helps us being more accurate to truly or more accurately stage the disease. All right, so that was just an overview of goals of PET, characterizing the tumor biology. The neuroendocrine tumors, in general, the low-grade tumors have expression of somatostatin receptors. They may have more or less expression of somatostatin receptor, but lower grade tend to behave like that. When we are into higher grade tumors, then the tumor starts to lose the expression of those somatostatin receptors and tends to be more active metabolically. So if the FDG PET CT is glucose metabolic activity, so we know that in general the tumors that are more aggressive, higher grade, they may be more positive on FDG PET and less positive on Dotatate PET. And this is just one example of that. This is a patient that had a Dotatate PET and FDG PET. The Dotatate PET shows liver lesions here, but these lesions do not show up on an FDG PET. This is a different patient that does not really show up much of lesions on the Dotatate PET, so the serotonin receptors are not so much expressed, and the FDG PET shows a lesion. So this is, you can kind of, again, characterize the biology of the tumor on the imaging. So see which tumor is more aggressive and which tumor is not as aggressive, which again has implications for the treatment. And this is just reiterating that. And what there were studies that looked at the neuroendocrine tumors that they are more higher grade, but also they have FDG, positive on FDG PET, so that tells us the tumor is probably more aggressive, and that's true. So the patients that have, where the tumor is positive on FDG PET, they tend to have a worse prognosis than patients where the tumor is not FDG positive, and actually positive on a Dotatate PET. This was one case, an unfortunate case that we had at Georgetown. The patient initially was thought to have a different tumor and then an FDG PET. So really, there are a couple lesions here and here that they were positive on FDG PET. But then we realized the pathology came as definitive for neuroendocrine tumors, and so we did a Dotatate PET. So you can see how many more lesions we can see on the Dotatate PET than on FDG PET. However, unfortunately, the tumor progressed, changed its biology, and so before we could treat with Lutathera, and that's how the FDG PET changed. So now the tumor has completely changed, it's become more aggressive, and you see lesions in the liver. So again, helps us. Obviously, this is a patient that is no longer suitable for treatment with Lutathera. And so that's how PET can help us characterize the tumor. We use PET to plan the treatment, to plan particularly treatment in general, but also to plan the treatment for with the lutetium dotatate type of treatments. Lutathera is the one that's approved, this is, we look for areas where the Dotatate, the somatostatin receptors are expressed, and that's because that's where the lutetium is going to go when we do the treatment. So we want to confirm that our target for the treatment, the somatostatin receptors, are there. And so these are two cases of two different patients where you can see this patient has some lesions here. all right? And probably there are some others which I cannot see, but they have relatively lower expression, lower activity. It's kind of similar to the liver in a way. And then you see this patient here where the liver lesions are really, really hot in a way, so high expression of somatostatin receptors. So that tells us that this patient is going to do better with the lutetium-177 dotatate treatment than this one. Because again, we are seeing how much of a target is expressed in the tumor by using the PET. So this patient has a lot more expression of the somatostatin receptors than the one on the left. And sometimes, even within the same tumor, we have parts of the tumor or different lesions that behave differently, right? So we have this patient here. This is this is from the literature, but it was a patient had liver lesions, and you can see how on a dotatate PET how active this is, so how many dotatate somatostatin receptors are here. But then you also realize that there is one area here that is FDG PET positive, so it's probably one lesion that's more active. And now in planning for treatment, what do I do? This lesion is a more aggressive part in tumor. Do I resect it? Do I do an IR procedure? Who knows? But again, that helps us characterize the tumor. Going to go a little bit faster here. We can use PET just like we use CT or MRI to see how the tumor is going while we're treating it, right? So assess the response to the treatment after either systemic treatment like Lutathera or chemotherapy, or after local liver treatments. This is a patient that had these are small lesions in the liver. On a follow-up, you can see a little bit more clearly there are new lesions that are seen here on the PET, so PET helps with that. But sometimes MRI can show lesions that are becoming larger when it's actually not really the case, and so PET can help us verify there are no larger new lesions. And that's because sometimes when the lesions kind of die off, especially in the center, they seem to be larger, but as a matter of fact, they are not. So again, the integration using CT or MRI together with PET, that really helps us most of the time. So that's how we do it. That's how we do imaging in patients with neuroendocrine tumors that are referred to us for treatment with the lutetium-177. So this is the initial staging. Again, I can use a CT or MRI on PET to confirm that the target of our treatment is there. And so the patient either undergoes surgery or is treated with octreotide. That's the initial treatment, right? And then I can barely see. So, right, so once the tumor is diagnosed, then the assessment of whether surgery or not can be done. A patient is placed on octreotide, and then if the tumor progresses, and that's verified by CT or PET, we can use also PET to verify that the tumor is now growing, new lesions are present. That's when we would consider lutetium-177, so the radioisotope targeting of the lesions. And so that's indicated for patients who have already been on octreotide, they were in a first-line treatment, now have progressed, and now we're thinking about lutetium-177 treatment. So, so we do that, and then we typically, at the end of the treatment, we follow up with CT MRI after 3 or 6 months, and then later on with PET as needed. So that's usually what I tell my patients, this is the follow-up we're going to do. Obviously, if we have any concerns, the tumor is progressing, is becoming larger, while we're treating, we might do CT or MRI earlier on, or even a PET. I don't know if this, I might have put this in the wrong place, but this is to show you that there's there are different tracers. There's gallium-68 dotatate, which is NetSpot, and more recently, a copper-64 dotatate, which is DetectNet, commercial name, has been approved, and gallium-68 also Dotatate have been approved. Essentially, these clinically, they're all the same. So sometimes the patients or the referring physician refer to gallium PET, or sometimes a copper PET. And sometimes a patient then ask me, I would like to do copper, I would like to do gallium. The truth is, in general, they're very, very similar. So there's no real clinical difference between the different PET agents. And the radiation doses are very similar, so also in terms of how much radiation you as a patient would receive by doing a PET, this is very similar. All right, and this is another example, gallium-68 Dotatate versus gallium-68 Dotatate PET CT in neuroendocrine tumors. Again, another study that shows that there's no real difference between the two, so I wouldn't have a problem using one versus the other. So switch to the treatment for neuroendocrine tumors. Historically, the first treatments probably were done with indium-111, and then we have also in Europe, there's been a number of studies, we use also yttrium-90, and of course we come now to what is approved, what's the most popular, most usually currently of the radiation types that we use for treatment with radionuclide therapy, which is lutetium-177. The difference between these types of activity is how long the radiation stays, travels into the tissue. So you can see it's a 0.02 to 10 microns is 12 millimeters for yttrium, is 2 millimeters for lutetium, and the type of energy and the half-life. So the half-life essentially dictates how long you have to follow also your radiation safety guidelines once you have a treatment with one of these agents. But they can have slightly different indications sometimes. Indium-111 is really not much used anymore, but again, lutetium-177 is the one that we are currently used for clinical practice as approved for treatment. And then there are the alpha emitters like actinium-225. That's one of the others that's been in the evaluation. So actually, I didn't put that here. I like to pause between slides, as you can see, to make you, give you more time to look at the slides. Of course, I'm kidding. Sometimes it gets stuck. So, a treatment schedule, and I have the excuse because I'm not watching the clock now anymore. But these are the treatment schedule. So, it's 4 treatments every 8 weeks, and you can see. So that's timed on when, if you're on lanreotide or octreotide, when you will be getting your octreotide or lanreotide. So essentially, every 2 administrations of lanreotide or octreotide, they're giving every 4 weeks. We do the treatment with the lutetium-177. Again, that's done every 8 weeks. So the total treatment time is 6 months. That goes better. So, these are some of the responses overall across one study or a combination of studies. So you can see PR plus CR is a partial response, a complete response. You can see overall across the study anywhere between 30 to 35, maybe one study a little bit higher, where the patient had either complete response or partial response. The vast majority of the patients, ranging from 30 to 50% of the patients that were enrolled, had a stable disease. So the treatment was able to stop the growth of the tumor, but not really shrink. And then there's a number of patients that range from very few to up to 10, 15% of the patient, roughly. I'm sorry, looking at the wrong one here. So yeah, anywhere 10 to 15 to up to 25% of the patient had actually progression. And these are the differences in overall survival. So overall, there is a significant response for these patients. Just to give you an idea of what is the more expected outcome when we do lutetium-177 treatments. And so these are the overall this is from the approved Lutathera, the type of toxicity that we can expect. So you can see often the patients will have, might have nausea and vomiting, but this was probably more related to the amino acids infusion, not to treatment per se for the majority. Fatigue is probably the most common complaint of the patients after they have treatment for a few weeks or a few days. and a few other side effects. And again, this is, but if you look at the severe side effects, there are really, really few severe side effects in Lutathera when compared to the patient that did not have Lutathera. And these are the abnormalities, lab abnormalities, or what is the effect of the treatment on renal function, of liver function. Again, you can see that there is a number of abnormalities in the labs. Most of the patient will have a reduction in the white blood cells, some anemia, reduction in the number of platelets, some increase or reduction in renal function, and some effect on liver function. But really, the truth is the severity, severe side effects are not as much, and not as many. And yes, there is reduction in the white blood cells, but again, that is overall not a lot of severe side effects from the treatment. If we can have a next slide. So delayed toxicity, these are most likely, most of the times, is either a myelodysplastic syndrome or acute leukemia. Very few patients, about 1.5% or 0.7%, depending on which of the two, will have myelodysplastic syndrome, which is an irreversible kind of damage to your bone marrow. It's not able to produce the red blood cells, white blood cells, platelets anymore, or again, leukemia. And this is about, you can see, about 4 to 5 years after the treatment that can happen. And then high-grade renal dysfunction happens in very, very few patients. I've actually never seen it, and liver dysfunction is also in very, very few patients. I have not seen it, severe abnormality. Thank you. Next slide. We use, this is ultrasound, but it's really PET. We use a PET to assess how likely is the tumor, is the patient to have a response or good outcome from the treatment. Again, the higher the activity, as we're saying, the higher the probability that you will have a good effect from the treatment. And so again, as you as a patient, when the doctor asks you, shows you the scan, you can kind of see how active your lesions are. The NET-1 study, which is the study that led to the approval of the lutetium-177 Dotatate treatment, again, enrolled in a number of patients, again, 115 patients in each arm roughly, and they were followed for 5 years, and again completed, the plan was completed all four administrations of Lutathera. If we can go on to the next slide, again, on one side of the patients, half of patients had only the octreotide, and the other half had the Lutathera plus the octreotide. Again, we know this data already. They've been around for a few years, but the overall outcome for the patients, the prognosis, the outcome was better for the patient that had the Lutathera. And you can see the progression-free survival is a lot higher. So these are patients that while they were followed up, the tumor did not progress. So that's how the progression-free survival. And so that's what the NET-1 study showed us, that the objective response rate, so patients had the complete response rate plus the patient had a partial response. There were a total 18% of these patients had this type of response, as opposed to those that did not have Lutathera. So 18% of patients that had the treatment had some form of response. Only 3% of patients did not have Lutathera had a response. So clearly favorable for the patient that had Lutathera. And overall progression-free, the progression of disease, 4% of the patients had progression while on lutetium-177 Dotatate, and 24% of those that did not have the Dotatate treatment. So you can see that 6 times more patients had progression of disease if they didn't have the lutetium-177 Dotatate. And about 60 to 65%, 60% of the patients had stable disease. Again, this is stabilization of disease is the most likely outcome of the treatment. And this is overall survival. There was some improvement in overall survival in patients that had lutetium-177, although this was an interim analysis, but then I'll show you, if you can go next slide. in the final analysis, there was, yes, a longer survival for the patient, but this was not really statistically significant. So overall, in the end, there was patients that were treated with the lutetium dotatate had a survival which is more longer than was didn't, although there was not a statistically significant difference, although there is some fewer more months for the patient who had the lutetium 177 dotatate. And of course, for myelodysplastic syndrome and leukemia, really the rate of that happening is, again, remained very low, about 1 to 2% of the patients, as well as nephrotoxicity, hepatotoxicity. So again, I have never seen in my patients a severe renal dysfunction, severe liver dysfunction. And luckily, I have yet to encounter a patient who have had myelodysplastic syndrome or acute leukemia. So these are fairly rare occurrences. Concerns or contraindication when we do the treatment. Sometimes there are patients where the presence of tumor in the abdomen is quite extensive, involves large parts of the abdomen. And so in those patients, there is a concern that when we give radiation, the side effects of radiation on the bowel and in the abdomen could be significant, can cause a significant inflammation or peritonitis. So some advocate for the use of steroids, so doing a steroids treatment to calm down the inflammation and prevent that significant inflammation can happen with the treatment. I've done it only once, and it's debatable how much it helps or not. But that is one area, one situation where we think about possible side effects we always think about side effects, but in these cases of a significant side effects to the abdomen. So again, PET helps us for that too, right? So PET helps us see the disease, assess the disease better, and see if there are large areas that could cause potential side effects. We talked about this. So this is the dotatate positive plus in the same tumor, an FDG avid area, which could be a little bit more aggressive tumor. What do I do with that? Because probably the dotatate, lutetium dotatate, is not really going to go as much in that area that is not dotatate avid. And so, again, correlating or talking to the IR doctor, to a surgeon, that can be something that can be helpful to see if there's any local treatment can be done. We talked about this unfortunate patient, again, high-grade disease. The efficacy of the lutetium 177 dotatate is lower in patients that have high-grade disease. In patients that have very high liver disease, or patients that have been highly pretreated in the liver, whether it's with radioembolization or prior chemotherapy, again, we have to be sometimes a little bit more careful because although I have never seen severe hepatotoxicity, but that's been reported in these patients that have been heavily pretreated in the liver, they might be more likely to develop a renal hepatic failure. Renal insufficiency, again, as you can see, there's some of this value may be a little bit higher in patients that are treated with the Dotatate. So meaning that the renal function is a bit lower in these patients, but the truth is that mild renal dysfunction is really not a contraindication to the treatment. We have treated some patients that were on dialysis, so that is also not obviously a contraindication to treat a patient who is on dialysis. In the future, I know there will be a presentation on a clinical trial, but this is one of possible future applications, future different uses of radiation, of radioisotope targeting. Actinium is an alpha emitter, it's a different type of radiation. This was one of the studies that was conducting in the patients that had prior lutetium 177 therapy. They had been refractory or stable on therapy, and so they were then selected to have a treatment with this tracer here, labeled with actinium, and you can see there was a 62.5% objective response. So it's quite a good response. And there are a number of clinical trials that are looking into that. This was one example from this group here. You can see this patient had a PET study. at baseline, and this is after treatment with actinium-225, the alpha emitter. Of course, that's the best example, but it's a promising treatment. And in terms of side effect, you can see how these are, again, grade 3, grade 4 are the severe side effects, and really there's not a lot of severe side effects in at least this, I think, was about 32 patients, so not a very large group, but still, these are from this small population, so initial preliminary data tells us that the side effects profile is actually quite favorable as well. And this is also in terms of effect, in terms of nausea, vomiting. For some, it's similar to what we have seen with Dotatate, so overall not too much of a difference. So that was my last slide, and I thank you so much for your